Once again, we're gonna replicate this the study published in JAMA in 2020. And in this study, I used the three databases across the countries. The first one is Ticagrelor, which is a trial database from United States. And second one belongs to IQVIA, which is an EMR, aggregated EMR data from the United States as well. And third is the Korean database, which is a reimbursement or claim database. I used the three databases for the study, and I agreed the results from these three different databases to get to conclude some the results about the comparison between Ticagrelor versus Clopidogrel. And even though it is a tutorial, I'm spending 30 minutes to assess the brief background of this study first. So why did I start this study? So this is the history of the DAPT or dual interplate therapy in patients with coronary artery disease. From 2090, from 1996, the aspirin started to back up the patient with coronary artery disease after the statin graft, and then Clopidogrel emerged as a the component of dual interplate therapy. From 2009, when the Plato trial was published, the Ticagrelor emerged as a new component of the dual interplate therapy. In that study, in the Plato trial, the Ticagrelor reduced the primary endpoint, which was vascular death, cardiovascular infarction, and stroke, without increasing the major bleedings in this study. So after this study publication, the American guideline and European guideline recommends to use Ticagrelor in the patient with acute coronary syndrome more than Clopidogrel. So if there is no contraindication that the clinicians should prefer Ticagrelor better than more than Clopidogrel in these patients. But in this study, when we investigate further, that there is substantial heterogeneity in treatment effects between the populations. So in the North Americans, it seems like the Ticagrelor is worse than Clopidogrel. But the most beneficial effects was driven by the people from the Europe or especially the Central Europe. So once again, and in Asia, even though the direction of the risk estimates is towards the benefit of the Ticagrelor versus Clopidogrel, but it is not significant. There are some hypotheses that aspirin dosing might matter. So, because more patients in the United States than in the rest of the world took the median aspirin dose more than 300 milligram per deciliter, milligram per day. So that's why there is a heterogeneity, but we don't know about that. And this superiority of Ticagrelor over Clopidogrel has never been replicated in the RCTs following RCTs. In the popular age, which was published in the Lancet, there is no significant difference between the Ticagrelor versus Clopidogrel, but Ticagrelor induced more bleedings. And in the Philo study, which was a multinational study conducted in Japan, Korea, and Taiwan, there was no significant difference. Actually, the bleeding was higher. The bleeding risk was higher in the Ticagrelor group, and then composite endpoint actually seems higher in Ticagrelor versus Clopidogrel. Once again, the Tika Korea study, there is no significant difference between the primary endpoint, and then the safety endpoint, which was bleeding, was higher in Ticagrelor. So the superiority of Ticagrelor over Clopidogrel has never been replicated in following small RCTs. In another study, which was just published before my paper in JAMA Internal Medicine found that when they used Canadian Percutaneous registry, that MACE, the major adverse cardiovascular events, was not different between the two groups, two drug groups. And so I wonder whether this newer and more potent inhibitor, more potent antiplatelet drug was better than previous conventional drug. And the introduction of new drug may exacerbate the socioeconomic health disparities because it's much more expensive. So the aim of this study was to compare the risk of net adverse clinical events between Ticagrelor versus Clopidogrel in patients with acute coronary syndrome following percutaneous coronary intervention through Odyssey network. You heard about Odyssey, the observational health data scientists and informatics, and the previous slides or presentations. I want to state our missions, vision, and values of Odyssey. So the mission of Odyssey is to improve health by empowering our community to collaboratively generate the evidence that promotes better health decisions and better care. And the vision of Odyssey is the world in which observational research produces a comprehensive understandings of health and diseases. It's not just like, standardizing data model or standardizing or making more data into a multi-data. We do have 6 objectives: innovation, reproducibility, openness, community, collaboration, and beneficence. So we try. I do not know this translation is good. Whether I can read some of the kind of like community, right? Yeah. Community. Yeah. Yeah, I can read something, but I can until please invite me once again. So then my Japanese improved at then by then. So once again, we are trying to conduct very innovative science, and we really think that reproducibility is very, very important. So your study should be reproducible if it is an obvious study. And we are very open. We pursue community, we pursue collaboration, and we pursue beneficence. I felt these objectives when I first joined the ICU, and it was maybe in 2016. And because I'm an Asian as well, as you can see, and then I've never stayed in other countries more than 2 months. So I've never spent my life in other countries than Korea. So, many times when I join the international group, that we can see some kind of the like hurdles, or we can see some, we may still feel some kind of the racism in that community, but I cannot feel that in the opposite community because they are really open and they really pursue community. So that's why I commit myself to Odyssey. And when I submit this paper to JAMA, then this is one of the hundreds of comments from the reviewers and editors. One reviewer wrote this to me. So he or she said that this remains a hopelessly flawed observational design using claim database to compare efficacy and safety. Despite all the care taken by the authors, some critical information is missing, such as duration of actual therapies and blah, 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 blah. So it's, when you get the comments from the reviewers, from the very privileged journal, like such as JAMA, and how you can react against it. This is my response to that. Even though I appreciate your comments. Oh, yeah, because you are a reviewer. Yeah, reviewer is correct that we are missing some information. But we emphasize that our approach represents a significant advance in observational research. We balance thousands of variables. We use 96 falsification endpoint, which I will introduce later. And we published our entire protocol and all our source code before running our trial to prohibit opportunity for p-hacking. We ran across databases inside and outside the United States, and we ran large set of sensitivity analysis to assess the robustness of the findings. So we showed the rigor of observation study, and this is not just like using many databases. We use very advanced techniques, and the talk of today will be focused on how you can do this research with very rigorous methodology. So these are some of the list of the strength in the methodology of Odyssey study. So as we use the standardized data set, we can standardize the analytics. So if you are just compliant with the Odyssey framework, then you will follow these strengths in methodology of studies. There is some, first of all, the reproducible and of science. Once again, the reproducibility is a very important concept in all these studies. So if you remember this, that there are two papers published in NEJM and Lancet in 2020 about the COVID-19. These two papers were retracted because of the data was fabricated. So, and this shows that these privileged journals, did not take care of the reproducibility and the openness or scientific integrity as they claimed. In Odyssey, we usually open our end-to-end executable statistical program at GitHub. And if you go to my study in GitHub, then you can see what happens. This is, I'm sorry that this is in a dark mode, so you can easy to see this, but this is my study repo. And I've uploaded the code or revised code 137 times. So you can see that 137 comments. And if you want to see what happens during 137 comments, you can click it. So sometimes, the reviewers want to test Cox. The reviewer asked me to test Cox assumption test, so that's why I revised this code by this. So you can see how I introduce Cox assumption test by using this code. Or sometimes I want to add some more outcomes such as MACE with DAS. So then you can see how I change this code to analyze and to add the outcomes. Or sometimes I revise my protocols, statistical protocol, and then it was recorded in this GitHub. So it's very fully open, and you can track what I did for the studies. So the dentists that much about the EMA, the European Medicines Agency, which is kind of the European FDA, and they mentioned about the Odyssey studies, about to endorse the reproducibility and open science in our system. And another strength in methodology is that, once again, pre-specification of your own study. I think that you can imagine how much time you need to spend to write the pre-specified protocols. But as Danny said, because most of our studies are very standardized, so you need to change just drug names or album names to make your own study protocols. So it's not really that burdensome as you imagine. I revised the graphs many times, and then I published it all to the GitHubs every time. My outcome was the composite of recurrent myocardial infarction and revascularization, ischemic stroke, intracranial hemorrhage, or gastrointestinal bleeding, which is the composite of the ischemic and bleeding event of these patients. And the individual endpoints was or secondary endpoints as well. The individual outcomes were defined and then published in the statistical protocol. And I want you to recommend you to use active comparator new user report design, which is kind of the very central principles of Atlas. The Atlas is the program you will learn today from during this tutorial, and this program actually mandates you use active comparator new user report design. So I defined the active comparator of Ticagrelor. It was Clopidogrel. Active comparator means that indicate the same the treatment, either it can be drug or device or procedures, which has the same indication of your target procedure and target treatment. And then new user means that there should be the index date should be the start date of the treatment. My treatment was PCI, so my index date was PCI. The index date is very important in studies and in Atlas. So my including criteria was adults who initiated Ticagrelor versus 4 Clopidogrel due to acute coronary syndromes and under 2 percutaneous pregnancy intervention PCI. And I excluded those who have the history of stroke or gastrointestinal bleeding or who used Prostrel or opposing drug within previous 30 days. And the 30 days was the washout period in this study. Once again, the active comparator new user report design is very important in pharmacoepidemiology beyond the statistical advance. So if you are interested in this, then please read this articles to learn about the active comparator new user report design. And of course, we use 3 large databases from US and Korea, which is another strength of this study. So we use Optim, Panther, and IQVIA's hospital data, and HERAS, which is a reviewer of which owns the nationwide claims. So we enrolled only the patient with PCI, which was 0.4 million patients. It represents the whole population in Korea. And we used 96 negative control for falsification endpoints. So falsification endpoints means that the outcomes which does not have any relationship with target or comparator. So outcomes which is not related with the Ticagrelor or Clopidogrel, such as like fracture, would not be related with the antiplatelet, or like cough. Maybe cough is cough can be related with it, but like sexual transmitted disease that will be not related with the Ticagrelor or Clopidogrel. So we select the 96 falsification endpoints. And the formal definition of a narrow control outcome is the one that shares the same potential for sources of bias with the primary outcome and cannot plausibly be related to the treatment of effect. So yeah, these are the list of my negative outcomes or falsification endpoints in the study, like abnormal reflex, alcoholism, aphasia, assault, atalaxia, cachexia, zone, closed fracture, like that, and then time carries. So once again, no use of falsification endpoint can be a limitation in after-risk study, because when you conduct after-risk study by using very big data, it's very, you can easily get the very statistically significant results because you are using very big data. So the p-value tends to be less than 0.05. But if you that it can be biased by any source of bias. So we can say that there is a possibility of systematic bias. And to measure your systematic bias in your observation study, I recommend to use falsification endpoints. So we don't know that even though we balanced the 20 variables we selected, but there can be subtle bias between the two groups. Then the one group can have more atalaxia or alcohol relation versus the comparator group. It's possible, and you can measure it, and you can evaluate your own study by using this, and you can calibrate your results as well. We use large-scale propensity model and a large set of sensitivity analysis because you are using very synthesized data set. There is very many tools to support very advanced techniques. So I use many different analysis, including time windows, different time windows, different statistical analysis, different blanking rules, such as there is two time windows, 1 treatment, 5 year, and 1 year, and we have four different PS matching strategy: the one-to-one PS matching, one-to-one matching with blanking period, variable ratio matching, which allows 1 to 10 matching, and PS stratification rather than matching. So the combination of these different things actually results in 144 analysis. So when I conduct this study in the IQVIA server, because IQVIA have very large data set, and it took more than a week. I remember, so they just claimed that, IQVIA claimed that, Chad, your study, it's still running. What happens? Because I modeled more than 100 analyses, so it's very very long time. But still, it's not due to calculate this. It's computer or server to calculate all of these results. So you can do this. So this is the results of this study. So we balanced more than 10,000 variables. We used these 10,000 variables in the PS model. So you can see that among these 10,000, more than 10,000 variables, no single covariance exceed the balance, exceed the 0.1 of strength of the mean difference. And when we use 96 falsification endpoint or their control outcomes, that you can see that more than 95% of them actually were not significant, which means there is very minimal systematic bias in the study, and we can calibrate the risk estimates based on the result from the negative controls as well. And we found that the risk of the NACE, 1 year NACE, was not different between Ticagrelor versus Clopidogrel in 3 databases respectively. And when we aggregate them into one single result, we found no significant difference between the two groups in terms of our primary endpoint. And this is consistent over the very many sensitivity analysis I said to you. And this is a risk as the distribution of risk estimates. So one count means that one estimates from the study. And you can see that in the meta-analysis, when we aggregate all of the results from the 3 databases, that and this blue or red line means that indicates the results from our primary analysis. So there is one primary analysis and 144 analysis from the results from the secondary analysis. And it looks like if it's like normal distribution with the mean of the primary analysis. So it shows very robust findings or rigorous findings of our study. This is a result for the secondary outcomes, and we found that Ticagrelor increased the risk of hemorrhagic events compared with Clopidogrel in these patients. And this is consistent over sensitivity analysis. So in summary, there appears to be no significant difference in 1-year NACE risk between Percutaneous versus Clopidogrel users, but it says following PCI, and this finding for primary endpoint were consistent across the Ticagrelor, and Percutaneous was associated with a higher risk of hemorrhagic events and SNIA. Once again, I've got this response from the reviewers of JAMA, and because I use the significantly advanced techniques in the observation research, I can reply to this comments. So I hope you to take this away too. Once again, our mission of Odyssey is not just build a data network. We hope to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. So we want more, reliable evidence by using observational studies based on standardized data set across the world. These are the objectives of Odyssey we pursued. International interventional cardiology is ever evolving branch in cardiology. So it may not be reasonable to stick to the evidence generated a decade ago in interventional cardiology. I believe that observation study also can generate higher level evidence. But for that, you need to pre-specify your study protocol to avoid p-hacking, and you need to use robust study design and control at least observed variables. And finally, there are many people believe that observation study cannot show the causal effect relationship, but in theory, the objective of observation study is the investigation of possible causal effect relationship, and for this, you need to use rigorous approach. Let's see, and this is the background. So today you will replicate this study. It's kind of a needed replication. You cannot replicate this study because I refined this study protocols and pipelines, statistical analytic code by more than 100 times. You cannot follow this, from today. But like Ben said, there is an off-the-shelf tools you can. You can replicate the study very simply. So I will show you how you can do this. So we will gonna have 4 or 5 teams. I think that we have 20 members in this lecture, but in this tutorial. But if we have more people, then it doesn't matter. And because I prepared 5 instances, so you need to make a team together, like 4 or 5 people together into one team. I know that it's not America, so you want to make a team with your familiar your friends or colleagues or your familiar members. So it's all your decisions. So please make a teams with